Are you guys still connected? I'm hearing a little ding-dong noise.
I think they start on Monday.
Yeah, we can hear you.
Okay, excellent, good. Don't want to start giving away all my secrets to working in patients if you guys can't hear me. Okay, so let us get going today. So what I want to start with today is to have kind of a little class outline of objectives and kind of tell you a little bit of my style of how I work up a patient like this, which is a very complicated patient. And then we'll go through and get into the actual problems themselves. So, I actually had so some of the fourth years told me that I get poked fun of for this, that I say there's a lot of ways to skin a cat. These are my 3 cats. There are a lot of ways to skin a cat when it comes to working up a patient like this. So this is 100% my style for how working up a patient would happen. I do think it is very applicable to you in this class, but if you decide that you want to do it a little bit differently, a lot of ways to skin a cat, okay? And I think that's fine. But the big thing I would tell you is that in this class, you need to figure out what your own style is and then practice it the same way every time. Because that way you get better and faster at your way, and when you get to the exam, you're going to be in a good place. All right, so for me, I start with what I call the basics. Like, did you look at the MAR, basically? So I pull up the med list, and I look for things that to me are kind of low-hanging fruit, kind of get me warmed up. So I look for things like drug-drug interactions. This is basically just like plugging it into Lexi, seeing what pops up. Renal dosing. So go get a quick creatinine clearance, look at the drugs and say, is there anything on here that speaks to me as needing to be renally adjusted? Some people do it even the other way, where they look at the drugs and say, doesn't anything need to be renally adjusted? Then they will look at the creatinine. However that works, speaks to you. And then finally, order entry. So this is always an issue where it's like the route, the directions, the dose, stuff like that. So like when I come in someday and like they've managed to enter the pediatric form of cefepime, and so the dose is 2,001 milligrams of cefepime, and it's like that's just an order entry thing. I'm going to give 2,001 milligrams to an adult, we'll just give them 2 grams. So little things like that. Okay. The next thing I say is, this is a pharmacist mantra, every medication should have an indication. That is the truth. Okay, you need to have an indication to be on medication. One of the ways that I will think about this is that I will say that no medication is benign. So that means no medication is benign. That means every medication is somehow harming your patient to some extent. So you're starting in the red. You're already hurting your patient by giving them that medication. So you need to have a benefit that is then outweighing whatever harm it is that they have from taking it. Okay? Now, one of the things that you will see that I would say physicians are very guilty of, but you can also be guilty of, is they'll see someone be prescribed like a PPI and be like, oh, they have GERD. It's not how that works. You don't have a PPI and then develop GERD. You have GERD and then you need a PPI. So you want to make sure you are actively looking at like, okay, maybe they have GERD, and then you go look, do they actually have GERD, okay? So this is a very easy thing. You can screenshot it, print it out, you can write little notes next to yourself, like what is the indication? And if you're struggling to find one, you maybe have jumped on a problem. To me, this is like real simple. Again, you're just kind of getting yourself warmed up before we really get into things. Then from there, what's the bigger system? You can use the 7 medication-related problems. So this is like dose too high, dose too low, missing medication, stuff like that. We'll talk a little bit about fast hugs, BID, which is more of a critical care thing of looking at the specific things that we need to look at every day, as well as you can go through and go by systems. So these are the 7 medication-related problems. It's a good thing to have memorized. It's a good thing to think about when you're going through your patient, is are you seeing anything that falls into these? And so you think about them, you look at your patient and say, okay, I think I'm seeing something. This is fast hugs, BID. The reason I like to mention this is what's done on any patient that is in an ICU setting, of which this patient is. And what I really like to highlight here is that so many of these are directly pharmacy related. So we're involved with TPM, we're involved with analgesia and sedation, we do VTE prophylaxis, we deal with stress ulcer prophylaxis, we do blood sugar, we do bowel regimens, all that kind of good stuff. Interestingly, there was recently a study that came out that showed that pharmacists actually improve all of these. So even the head of bed and the indwelling catheter and all of that, it turns out the pharmacists are really good at having a checklist, looking at a patient, saying, do they need a checklist? And if they don't, they say, hey team, we should get rid of something. So this is another thing that you can use specifically for ICU patients. So what I want to do today is to globally look at what is the one-liner for this patient. So when I say a one-liner, this is actually kind of a challenge in some ways to kind of come up with what is this for the patient. So So if you start to just read me the entire HPI of the patient, that is not a one-liner. So we're looking for, they're a 55-year-old male with past medical history of X, Y, and Z, presenting today with this disease state and these complaints. So if you can develop that in your mind, it's going to help you throughout the entire process, all right? This is, again, looking more at the big picture. Then again, we're going to do the basics. We're going to look for medication orders or errors. We're going to do a drug-drug interaction check. We're going to do some dosing. Then we're going to make sure we can assign an indication for each medication. Make sure we know the monitoring parameters for each of those. We're going to figure out what is the most important problem, both for the patient as well as from a drug-oriented perspective. We're going to identify why it's a problem, and then identify the solution and why it's a solution. The reason I think this is important is that when we start talking about the exams, this is exactly what you're going to do. You're going to come in. I recommend warming up with the one-liner. Again, one sentence. Don't give me a whole, and then their cousin was doing this with their dog last week. I don't want all that. One sentence. And then you're going to say, the first drug-related problem is this. It's a problem because the drug-drug interaction, class B, can cause this. What I want to do is this. If you get that, you get all the little points, and you're going to sound great on our patients. And then we're going to go through and evaluate kind of all the systems to make sure that we reviewed all the aspects of this patient to kind of come up with some of the other things that are probably considerations that you thought about when you were working up this patient. All right, so that being said, what is the one-liner? Can I get, just start with group one. What would you say, how would you describe this patient to me as succinctly as possible? I'm also always down for phone a friend if some of the group wants to come in.
Patient is a 74-year-old male who presented to the clinic, or presented to complaining of abdominal pain that didn't go away after being discharged from the hospital last week.
Perfect. So this is what I had. I had a little bit more detail in here, but I also didn't give you much of a heads up. So, to me, this guy is a 74-year-old male. He's got a past medical history significant for heart failure with reduced rejection fraction, specifically an EF less than 15. He's got hypertension, AFib, hypothyroidism. He had an MI a couple weeks ago, or last week. Had PCI with stents. That's kind of a big deal, and you're absolutely correct. He presented with abdominal pain that has not been gone away, and he was found to be in cardiogenic shock. I did add one extra sentence. He was sort of milrinone. Now it's a couple days later. So if you can kind of work on developing this for yourself, you will find that it helps you to organize all your thoughts about the patient. So you know kind of who this guy is, you know what's happening in terms of like what brought him in, kind of what's the major thing we've done thus far. All right. So big picture, what do you know just by looking at the MAR? Okay. So group two, when you guys look at this, what do you see that kind of speaks to you of things that you think might be going on? Again, you haven't, I know you've looked at the chart, but pretend like you haven't. What would you kind of see when you look at this?
The slide is very blurry. We can't.
So when you guys pull up the MAR on EHR Go, and you see that they're on Synthroid, metoprolol, spironolactone, Eliquis, statin, Lasix, what do you start thinking about for a patient like this? That doesn't make it any better.
We think about if like his current Medicaid or what indication his medications are treating, and if he has enough medications for all of his indications.
Sure. I think that definitely is a good process. So for me, I kind of start to create like this general picture in my head. So I'm looking at this, and I already know the one-liner. He's got some heart failure. He just had an MI, and so I'm like, okay, so this makes sense. I can already see kind of where the metope fits in, spironolactone. He had AFib, and here's my Eliquis, that kind of stuff. He had stents, so you got dual platelet on here. So things that kind of show up kind of got a heart failure regimen going on. And probably, we know he had an MI, but hypertension, MI, kind of those things are going on. He's on Eliquis. So kind of like you see Eliquis, either it's a mistake, it's AFib, or it's a DVT, right? So, you're thinking through it from that perspective. To me, triple therapy immediately jumps out with the fact that he's on Eliquis, aspirin, and Plavix. For me, I'm always kind of looking for is he intubated or not. So the fact that I'm not seeing fentanyl, midaz, chlorhexidine, I'm like, okay, not intubated, that's exciting. There's certainly a lack of antibiotics. I'm used to kind of looking for antibiotics. It doesn't seem like he's infected. So either this is a huge problem that he's, has an infection and we're not treating it, or it's not an issue for us. So that's kind of nice to think about. And lots of PO meds. So that kind of puts you into a certain mindset, right? When you're looking at more PO meds than oral meds. And I know this is kind of a global way of thinking about it, but I think that this is very helpful for you to kind of make sure I think to me, one of the pharmacists can be very much the leaf on the one tree in the forest, and I'm just kind of trying to make you step back a second and just kind of assess what is the forest doing, okay? Okay, so what problems jump out? So group 3, when you looked at this, did anything just jump out at you as like something is definitely confusing or wrong? You definitely have a question. I know it's blurry, but when you're looking at it on your EHR go, what do you see?
We noticed that he's on sertraline and there's no indication for it.
I think that's a great one. We don't see that on there. What about group 4? You guys see anything else that was interesting to you?
Decompensated heart failure, and he's on metoprolol tartrate instead of succinate. I know succinate's more preferred.
That's a great one. That's an excellent one. I actually didn't even have that on my list, so props to you. So things that to me, when I first saw this patient here in real life, that kind of spoke to me, was I immediately saw this metoprolol, which is a beta blocker, which reduces cardiac output, and I saw milrinone, which is an inotrope, which is increasing cardiac output. And that to me immediately struck me as somewhat pharmaceutically inelegant. There's something going on here that's not quite right. I don't really have an answer for you, but I at least know that that's something I want to clarify. Another thing that definitely popped out at me is the triple therapy. And the reason why this popped out at me is that from a clinical pharmacist in a hospital setting, most hospitals have a list of what they call high priority meds. High priority meds are kind of the ones that we have a narrow therapeutic index. They're easy to mess up, they require monitoring, all that kind of stuff. So like vancomycin, aminoglycosides, warfarin, apixaban, enoxaparin, heparin, all those types of ones. So anytime I'm very primed when I see one of the medications on a list like that, I'm immediately looking at that with a little bit more detail. So those were two that just kind of immediately popped out at me. I know this is something you probably haven't thought about in this way before, but again, just kind of tips and tricks. I think that this is something that can be very helpful, and as you practice over the course of the semester, I think you'll find you get better at this.
Dr. Newsom, we can't see in Athens what are the things that are in the boxes. We see the 3 red boxes and 2 blue boxes, but we can't see the writing.
I think what I'm going to
Same
do,
with-
give me 1 second if you guys don't mind. I'm going to save this and you guys can just have it on, I'm going to put it on ELC real quick. Does that sound good? And that way you guys can pull it up since it seems to be that there's an issue in this way. Let's see. Case 2. Does that work for you guys?
Yep.
Yes.
I love it.
Awesome.
Should have one with the dog.
All right. My request is please don't go ahead too much and ask all the questions. I want you to think through it, if that's all right. Okay. All right, should be up there. All right. Yep, you're very welcome. Okay, so metoprolol and milrinone are in the blue box. Triple therapy is in the red box. I did blue because I felt like it was like a lack of perfusion, and then mine is red because it's like bleeding. Alrighty, so ordering errors. When you guys looked at this, when you were looking at it this week on the MAR, did you see any ordering errors where you were like, something is not right about how the drug was entered? Even if you don't know if you even care about the drug, but it just looks wrong. Was there anything that spoke to you in that way?
think the metoprolol tartrate was entered wrong from the home meds.
That's an excellent thing to notice. So one of the things that's very interesting, I have a fourth year who was just on with me a couple months ago, and he goes, Andrea, I really don't like doing med rep because the reason is that they're actually in the hospital, and so I want to change everything they're on anyway. So why do I have to do a med rep? And I was like, it's an interesting point. So what I want you to realize is maybe I don't think that's the best attitude, but I also think that there is something that is, you can take from that. So when you look at a home medication list and you see what they're on at home, you need to then look at what they're on here and say, could this possibly make sense to you? And then kind of make a checking box for it. So I agree with you. If this is not the dose that he was on at home and it's different, that is certainly a box to note that this is different than what he was on, but could it potentially make sense to you? In this case, a guy that came in with what we're going to find out is decompensated heart failure, it's maybe not completely ridiculous that we reduced his beta blocker dose while we're kind of getting him to a new equilibrium. So we often have to do this in-house where they're on lisinopril 40 at home, they come in acutely hypertensive with an AKI, and we start back at 10. And we know that they were able to handle 40, and we hope they're going to get them back to 40, but we're going to start low and go slow. And so unfortunately, even though they were on it at home, and sometimes we're kind of starting over. So for this one, I really didn't have anything beyond this. All of the, it didn't look like we had a dose that was a weird tablet. We didn't have a wrong dose. It wasn't like there were duplicates on the MAR, that kind of stuff. And so this is a very clean looking MAR. I will give you a hint. My next case, when you guys hang with me in I don't know, 6 or 7 weeks, there's going to be a lot more issues, okay? And that is much more like what I usually deal with. So I would say almost every MAR that I look at when I come in, there's always some little doodad on there that's just kind of entered incorrectly that I'm going to clean up. It doesn't have necessarily to do with the indication or pharmacotherapy. It's just like the computer system has done something strange. All right, cool. So drug-drug interactions. So again, please enter all the medications into the drug-drug interaction checker when you do this. Then you're not going to like me very much because you see we have this absolutely enormous list of things that popped up. So my question for group 7 is, looking at this obnoxiously large list, did anything actually speak to you as like, this is something I need to be concerned about? Or were you concerned about all of them? How about group 8?
We thought the Plavix and the Protonics was significant.
Yeah, very good. Nothing else, you guys went to the next slide, right? But yes, very nice. I agree, this is the one that's significant. So how do you decide what's significant? So again, this is why you're going to make the big bucks at some point, is that it's going to be your job to look at this, which is just a computer program who's plugged in everything that we know about medication therapy, and it pops up for you to evaluate. So, when you look at aspirin and Plavix, if you were to click on this link, it's going to tell you that it increases bleeding. And you're going to say, I knew that, but I'm also okay with it because stents are a big deal, right? So that's the one where you just kind of roll right over. You're going to look at, sometimes you get weird things you didn't even know were an issue, and you're like, oh, I did not know. Like, I'm looking at aspirin and spironolactone right now, and I would actually have to click on that to remember what exactly they're saying is the interaction. Generally speaking, how I organize is I look at class D. It's usually class D and class X are the ones that I'm really evaluating with a hard eye. And then I'm looking at, does it make sense? Is this a known risk benefit? So again, aspirin Plavix, or aspirin Eliquis Plavix, we definitely know they're increasing bleeding. There's no doubt about it. But again, we're talking about fresh stents, we're talking about AFib. We know that that's a possibility, and we're going to continue therapy. But I agree, Plavix and Protonics, that should stick out to you. The reason why it stick out to you is because the patient had stents a week ago, for which aspirin and Plavix are level 1 indications, and then you've got Protonics, which everyone and their mother is on, and we don't even really know if he's got an indication for GERD or not. So now we're potentially putting this patient at increased risk of having a repeat MI, so that maybe he doesn't have acid reflux. That should hopefully stick out a little bit for you. Okay? So You click on it, aspirin Plavix, it tells you this, and you say, where should I go from here? So where this came from is when clopidogrel and omeprazole have an interaction based on 2C19. And basically how this has then kind of gone is that they've said that omeprazole is a class within PPIs, and so then it shows up with all of them. So if you ever want to go do some interesting reading, you can go look at our concerns with omeprazole and clopidogrel that it hasn't really hashed out with Protonix. So that's kind of where that comes from. So one, you can say, is it clinically relevant or not? And then two, the question you should always ask is, do they need to actually be on a PPI? The other part that I think is worth noting, this is in the guidelines, when you're talking about patients that are on triple antithrombotic therapy, and it specifically recommends a proton pump inhibitor. So again, when you're looking at it in the clinical context of something, you have to kind of use multiple sources to come up with what your opinion is on this. All right, so in this situation, the patient is on triple therapy, and it is not omeprazole, so I'm probably going to keep going, but I think it's worthy of noting that it is class D. Okay. Awesome. Is there any renal dosing for this mark? Who are we on? 9? How about group 10? Either any of you guys see anything you want to adjust based on their renal function?
The patient's Eliquis should be dosed renally at 2.5 milligrams twice a day.
Yeah, so we could look at that. Let's go to Alexia real quick. What other factors do they have based on? I think there are multiple factors we need to make sure that we're going to drop it down to their other dose.
So according to the guidelines, it says serum creatinine greater than 1.5 and either a body weight of less than 60 kilograms or greater than 80 years of age would decrease the dose to 2.5 twice a day. And the patient is not over 80 years of age and they weigh more than 60 kilograms.
Yes, but I do think you're bringing a very interesting point. You do have a medication that you do know is renally clear to some extent, and you do have a patient that you have correctly identified has something going on with their kidneys. Even if we're not exactly dropping the dose at this moment, the fact that you kind of create a box to that and are thinking about it, I think that's an excellent one to note. In this case, I probably am not going to do anything with this, but again, I do think it's worth just seeing, okay? All right, so nothing we're going to do there. So let's put together what goes with what. Okay, so did the patient have, in some point in their notes, something to do, an indication for synthroid? Yes or no? I'm just going to do by nodding in Augusta. You guys please nod in the other campuses. I'm hearing you nods here. Okay, so hypothyroidism, right? So it's in the note.
I do have a question about the Eliquis.
Yeah. What's your question for Eliquis?
So when I was looking at the package insert about renal dosing, I also noticed that it was contraindicated in severe hepatic impairment, and his liver function is really, it seems pretty impaired right now. So I didn't know if that was something that we should flag in the beginning as well.
That's very good. Now you're going to have to make me flag that for next year. So, okay. So I agree with you. That is an excellent package insert note. The question I have for you, which maybe is jumping ahead a little bit, is do you think that this has to do with, is this going to be a chronic thing for him? Is he like a chronic cirrhotic, or do you think this is more of an acute thing?
I think it was more acute.
I agree. So again, this is kind of why you get paid the big bucks. If you just have someone blindly read the package insert, we're stopping the Eliquis, right? But if you're saying, okay, it was acute, it's getting better, I think we're going to be fine, maybe you ride it out. But there also are situations where like it's so bad, you're like, whoa, I don't feel comfortable with that. So I agree, for next year I'm going to put another little box right here, maybe yellow for ammonia buildup, and I'm going to say, okay, I see where you're going, but I probably would continue it. That's an excellent point. Okay, so we have hypothyroidism. What is the metoprolol for? I have AFib over here. How about group 10? Give me another indication. I agree with AFib, by the way. But there's two other interesting ones.
For heart failure?
He does have heart failure. And then what else happened to him last week that's kind of a big Recent MI, yeah, awesome. I don't even have AFib on here. So MI, HFrEF, American Heart Association. So we feel good that he should be on metoprolol, right? That's a good choice. Question, at some point he should be on it anyway. And we're still kind of concerned about this Noradol, but we at least say that at some point we agree with that. It's not completely out of left field. How about spironolactone? What's that for?
Heart failure.
I get heart failure over here. Awesome. How about Eliquis? What's that for? AFibs. You have a good chat best score for it. I remember counting it in my head thinking it was like 5 or 6, right? 6. Yeah, awesome. What's he on statin for?
Secondary prevention.
Yeah, so secondary prevention of an MI would be the answer I'm kind of looking for. To me, that is like that's the trump card. Doesn't matter what his LDL is at this point. I want him on a statin. He had basically a major event. What's the Lasix for?
Heart failure?
Yep, heart failure, cardiogenic shock, something along those lines. Happy with that. What's the aspirin for? Stents, yes. MI with stents versus triple therapy, one of those options. What's the insulin for?
We don't really know.
Diabetes.
Yes. So the question that I have for you guys here is, I actually tried to go through and delete all the diabetes out for this patient. I imagine you guys managed to find one somewhere. So this is one of those where it's kind of like the what came first, the chicken or the egg. Almost every patient that comes into the ICU will end up with sliding scale insulin. Because critical illness can make your blood sugars do crazy stuff and all of that. So then the question for the pharmacist becomes, A, do they actually have diabetes? B, just because critical illness can cause blood sugar dysregulations, is it actually causing blood sugar dysregulations? And are we just sticking the patient 5 times a day for no reason? I don't know when you guys had to practice doing that. I hated that lab. I tried to avoid doing it because I hurts for a long time. I don't enjoy that. So I feel bad for patients when their blood sugars are perfect and it's all right, let me lance you 5 times a day. So that certainly sticks out. So I kind of had no indication versus DC. If you guys can find diabetes in the chart, I'm gonna have you guys ask me for it so I can delete it back out. I spent a long time trying to delete them all. Plavix, what's Plavix for? MI with a stent, absolutely. What's the Zoloft for? Oh, you guys can't find anything? Okay, I had depression on here. I'm gonna take some notes. So the upside and downside of this, depression, question mark, diabetes. Okay. So you guys have no indication. I'll give you that. This is one of those where a lot of times I go in and ask the patient, I'm like, have you been on this before? How long have you been on it? And then okay, we'll add that, depression to it. So this again would be a solid box for you to ask, where did this come from? Noradol, what's he on this for?
Cardiogenic shock.
Yeah, cardiogenic shock. And then Protonics.
He does have GERD.
He does have GERD.
Somewhere.
Yes. So he's got GERD somewhere, and he's also got triple therapy at the moment. So either way, we're going to have to be on that. Okay. So everything on here, we can at least somewhat argue has a potential purpose. Maybe the insulin we can get rid of. Maybe the Zoloft we need to go out clarify about. But we don't see any egregious things beyond that point, which is nice. Okay. So primary problem. So group 12. What do you think is the patient's biggest genetic problem?
Hey, Dr. Newsom,
Yes.
did the patient actually have depression? Because it didn't say that in the chart.
I will tell you in real life he had depression because I remember the patient. The fact that it's not in the chart makes me think that I'm going to go back and add it after class if that is okay. That's a good question though. What is the patient's biggest medical problem? Group 12. What do you think is what brought him into the hospital? What's the most concerning thing he's got going on?
We think it's that he's in shock.
Yes, 100%. He has resolving cardiogenic shock, likely secondary to acute decompensated heart failure. All right? And this, I think this is a story you can make up in your head that seems pretty reasonable. He's got an EF of 15%. That's pretty darn low. Okay, he doesn't have a whole lot of reserve. And they're telling me last week he had a major MI that has a couple of stents. So there's a possibility that he went home after that, his fluid balance wasn't just so. Maybe he got a bug in the hospital. Maybe he went home and he was so happy he, survived his MI. He went to Zaxby's, had a bunch of salt. We all know. But you can play the game with me here about how this could make sense. Okay. So given that this is the patient's biggest medical problem, what do you think is the biggest medication-related problem for this patient? Group 13.
Would it be the fact that he's on the beta blocker and the Norman?
Yes. To me, this is a huge issue. And there's a couple of reasons it's a huge issue. One, either he has cardiogenic shock that's resolved now, we fixed it, and we still have him on ninotrope, which is a medication that actually has been shown to increase mortality in heart failure patients. It's good for, it's called a quick fix, but not a long-term fix. Or you have a patient that's still in cardiogenic shock that you're giving a beta blocker to. So you have a patient with reduced cardiac output that you're now further reducing the cardiac output. So that seems like kind of a problem. What you got for me?
On the progress note, day 2 for the CCU, it said the Milburn drip was discontinued. And when I looked at the administration history, it looked like it hadn't been given in a little while.
Welcome to real life. This is exactly why I put it in like this. So what are you going to do with this? So the note says one thing, the MAR says another. Is it on? Is it off? Is this just as simple as you need to DC on the mark? Or is it that we need to make sure that the team, that something hasn't happened since that last note was written? So I'll tell you, in real life, what I would do when I see that is I would immediately just go to the bedside and talk to the physician and be like, hey, what are we doing? Has something happened since this note has been written? So for us, we have to do a little bit more detective work. So given that, the question becomes, what do you think is going on with his shock? Do you feel at this point he needs Milrinone? Or do you think he can maybe start on a low-dose beta blocker for his long-term mortality? How would you kind of look at that in terms of, give me an argument for whether you want to get rid of Milrinone or get rid of beta blockers. 14, group 14. So when you guys think of shock, let's start this way. What do you guys think, what is shock? What happens in that? What are we concerned about?
And organ damage.
Correct. So basically we're talking about, I think the broadest, best definition of shock is that you have a demand-supply mismatch, right? So whatever the body's demands are, your heart isn't supplying it, or your cardiovascular system isn't supplying it. And then as a result of that, you have some type of end organ dysfunction. So what kind of end organ dysfunction did he present with? I can think of at least three systems that he had a little bit of funk with, if you will. Group 15. What do you guys think? What systems?
His kidney, liver.
Yeah, so I have kidney over here, I have liver over here, so we're seeing elevated serum creatinine, we're seeing elevated LFTs, and they're going up or down at this point.
The serum creatinine is trending back down.
Yes, and so it's going back down, which is very good. There's also kind of an interesting one that he had. What was his primary presenting symptom?
Abdominal pain.
Abdominal pain, right? That's kind of interesting. Why was he having abdominal pain? He did have some fluid buildup, and that could definitely be it.
Inadequate perfusion.
Yes, so he actually had inadequate perfusion to his gut. And when it was lack of perfusion to his gut was causing him to have abdominal pain, so mesenteric ischemia. So that was kind of interesting. That was first what sparked my interest in this patient is he kind of had an atypical presentation of decompensated heart failure. He showed up saying, my stomach hurts. And then all of a sudden we were like, your EF is like 5, and your serum creatinine is super high, and your LFTs are super high. So he was in cardiogenic shock, all right? So that's kind of interesting to see. All right. Where am I going with this? he's in chronic HFrEF or do I think he's in acute decompensated heart failure? And the problem with this is I've screenshotted something from the same set of guidelines where it basically says in chronic heart failure, please definitely give a beta blocker. It's good for them. And then in acute decompensated heart failure, it's saying, hey, you probably shouldn't do that, and if you do, please go low and go slow. So that's kind of why we have to make an assessment of what's going on. And in real life, this is where we're sitting with the patient and we're trying to decide if we should start it back or not. Again, in the hospital, I'll be on the team and we look at the patient, they've been in cardiogenic shock, and we're like, all right, I think we're gonna start it back. And then we come back and a couple hours later, their blood pressure's super low, they're having a hard time breathing because they've had fluid build up, and we're like, oopsies, guess we weren't quite ready. And then we stop it, and we give more diuretics, do whatever we're gonna do, and then we try it again. But we wanna make sure that we, although there's a degree of guess and check, we wanna make sure it's a pretty educated guess, right? All right. So again, I wanna make sure you guys think about this from a hemodynamic perspective. This is my favorite equation. So you'll see it this time, next time, probably some other point in class. So when you're thinking about your blood pressure, that's your map. It's really a function of your cardiac output and your systemic vascular resistance. So cardiac output so SVR is squeeze, that's basically pressors. Cardiac output is what your heart's putting out. I think this is fairly easy to remember. What your heart puts out is how big the beat is, that's stroke volume, times how many beats are in a minute. All right? This is why beta blockers reduce cardiac output. They not only reduce heart rate, as we all know, they also can reduce overall the stroke volume, and that they reduce kind of how hard the heart is beating, kind of that intrinsic muscle, what it's doing. From here, stroke volume is a function of overall volume status and general contractility. And again, this is why when you have a patient that comes in cardiogenic shock, that's why you would give an inotrope, is you're going to support their cardiac output, which is the primary issue, by increasing the contractility and a little bit potentially the heart rate of what the heart is actually putting out, okay? Okay, from here, again, when you look at a patient like this, you're trying to work up where do you think they are in this process. So hopefully you guys have seen this at least once before in your life with heart failure. You have dry and warm and dry and cold and so forth. So how do you make the decisions? So a patient is dry and warm. To me, that kind of sounds like they're in a good place, right? Hopefully we're all dry and warm to some extent. So no extra fluid, we're all perfusing appropriately. Dry and cold means there's not a lot of fluid overload, but they're not perfusing their end organs very well. Wet and cold means they're probably have pitting edema, JVD, the full 9 yards, and they're not perfusing their organs. So that's also bad. And then you can have wet and warm, which is where they're perfusing their organs, but they're probably saying I'm really short of breath, they have 4+ pitting edema, or their JVD goes up to their neck. So in your guys' opinion, where would you guys put this guy? Do you think he's warm or cold? When he came in, was he warm or cold? Cold. Yeah, I'm getting cold in Augusta, and I would 100% agree. Cold to me means we're not perfusing the end organs. We just talked about 3 systems being affected. I would say that he's cold as well. In terms of dry versus warm, this is a little bit hard. You see that he has some Lasix on the MAR. We gave him some. And it's is that really just a maintenance dose for him? And that's kind of what he's always going to be on since he has heart failure? Or was it truly that he's wet? And this patient, you could kind of make it, I think you could argue me either direction, I can kind of believe you, but I would say that I think the overwhelming issue is the cold. So when you think about this, you can actually, if you make this your little graph based on your Frank Starling curve, you can actually decide what treatments you want to give this guy. So again, when you're thinking about someone that's fluid overloaded, the way that I think about this is that the more volume that you have in your LV, the more stretch you have, the more potential energy. And the more potential energy, the more snapback, more kinetic energy you can have, which is good. The only problem is when there's too much volume in the system. And so then I switch from kind of a slinky potential energy, kinetic energy metaphor to eating marshmallows. So if you like marshmallows, you're very happy, you're putting marshmallows in your mouth, you're increasing your cardiac output or your happiness as your marshmallows go up. At some point, there's so many marshmallows in your mouth you can't chew, right? You have all these marshmallows, then your cardiac output goes down, okay? So if your heart, your left ventricle becomes so distended from fluid, you can't push back, all right? So that's why when you have someone who's wet, what they're gonna recommend is diuretics. And you're gonna push them back up the curve to the perfect point of optimum stretch, but not too stretched. If you have someone that is cold, again, they're probably gonna need an inotrope. That's what this guy needed. He was on milrinone, and that's the whole conversation we're having right now is, does he still need it, or are we ready to start him on a beta blocker? All right, so skip ahead a little bit. Our patient is dry and cold. We agreed on that. What medications were discontinued because of this? Why, when he was dry and cold, what did we take off of his home med list while we were acutely managing him?
Metoprolol.
Yeah, we took off metoprolol. I thought he was on one other one. Yes, he was on ACE inhibitor too. Remember, he's got AKI. And again, he's cold, so we probably don't want to continue something that's reducing his blood pressure. What medications were added because of this?
The milrinone.
Correct. So again, when you're looking at a patient like this, and this is true of almost every patient that comes into the hospital for an acute issue, is you're going to look at their home med, you're going to take some things off, and you're going to add some things. And the question for you as the pharmacist is, can you rationalize what's happening? Can you argue that this is good or bad, or do you need to add something? So he shows up with his decompensated heart failure diagnosis. You're going to DC some of his heart failure medications because he's got a blood pressure problem, a perfusion problem. You don't want to keep reducing his blood pressure. You're going to add some inotropes, some diuretics, maybe a vasodilator, that kind of thing. Then you're going to be transitioning slowly from decompensated heart failure to just kind of regular heart failure where he has it all the time, but it's not an acute issue. And then we're going to start saying, okay, what evidence-based medicines do we need to start, and how are we going to titrate them? Does that process kind of make sense? And you're kind of coming in anytime, you don't really know where you are in the cycle, and so that's what you're trying to do. All right, so we added metoprolol, PC, held, restart, so we go. All right, I'm gonna put this up so that we can talk through it. So when you look through this, to me, the things that kind of stuck out to me are his blood pressure and his MAP, what his heart rate was doing, what his inotropes was doing, his ejection fraction, and then what his rhythm was. That was kind of my objective data that I was looking at. Then we start to assess the patient. We say, okay, we beat this to death. He has cardiogenic shock. We know he's got a recent PCI. It seems like we're weaning off milrinone, so we feel good about that. And of course, we've noticed that he potentially has this drug-drug interaction that we're okay with. So at this point, when you're guys looking at the patient today, what would you rather do? Would you rather DC the milrinone, keep the metope, or get rid of the metope, keep the milrinone? Yeah.
Dr. Newsom,
Yes.
if the patient's dry and cold, why are we putting him on Lasix?
So potentially, the question is, what is dry and what is euvolemic? And I think that's a great question, and I probably should be more precise in the wording that I'm using. So I think for a patient like this, there's three potential options. He's either hypervolemic, so too much volume. He's euvolemic, which means he's in a good spot. Or he's hypovolemic, which means he doesn't have enough volume. I think in this patient, when you're reading through the notes, I didn't see a lot of stuff that said he was hypervolemic. I didn't see a lot about a ton of JVD, pig edema, he's having a hard time sitting in the bed, that kind of stuff. So I'm kind of more at the point that he's probably euvolemic to maybe a little bit dry. And so the reality is a patient with an EF of 15%, they have to be on some Lasix. There is really no way to keep that patient euvolemic without that. So the question becomes, is this the correct Lasix dose for him to keep him in a euvolemic state? So I agree with you. You should definitely look at a patient and say, okay, like they do have heart failure. Do I think this is their maintenance dose, or are we actively diuresing? In this case, I think where we're at is more of a maintenance dose, and I think that that's okay. But it was definitely something that you need to have a box next to it, something that you're monitoring every day. That's a very good question.
Dr. Newsom,
Yes?
based on the Frank Starling curve, where is dry and cold?
Let's go back.
I might just be bad.
Let's see. Did I manage to put something in a... Okay. My own issues. So, okay, looking at this, you have volume is on the x-axis, so dry would need to be over here, right, so not as much. And then I have wet and dry here. And then you said where is cold? Cold would be a low cardiac output, so right here. Low cardiac output, low volume. Forgive my typo.
So the bottom left should say dry and cold. It's kind of hard to see in Athens.
Yes. Yes.
While we're evaluating the blood pressure right now, when I was looking at the blood pressure, I saw that he had a high diastolic. Is that because of the milrinone?
It can be because he has a high the milrinone. Could just be it could be a number of things. So many heart failure patients actually have a wider pulse pressure, so a lower diastolic than that. So he's kind of unique in that way. It could just be kind of an interesting quirk of him. I personally did not attach much meaning to it, although it is interesting. I will give you that. Worthy of a squinty eye, I suppose. Okay. So for me, when I looked at this patient, I felt like all of his original signs and symptoms of cardiogenic shock were resolving by day 2. Okay? He's not complaining of abdominal pain anymore. As we said, his serum creatinine is trending back down nicely. His LFPs are trending back down nicely. And at some point, we have to start him on some other things. We've weaned him off milrinone. He seems to be relatively stable. So I would think that we would discontinue the milrinone and keep the metoprolol going. That, to me, would be the reasonable plan. I also put in here, we can consider addition of hydrolysis and isosorbide to reduce SVR and improve cardiac output. I will tell you, I didn't put this as a formal problem on here because you usually don't want to do too many things to a patient like this at once. You gotta remember, like 48 hours ago, he was in a pretty bad place. You're not gonna make a ton of changes on him. So we're just saying we're gonna discontinue the milrinone today and feel good about it. We're probably not gonna start adding other antihypertensives on top of it. In terms of reduction of SVR, what is very interesting for heart failure patients is that they start to have this reduced cardiac output back up here. And so your body's smart and it says, oh, I don't have enough cardiac output. What I'll do is I'll increase SVR to maintain my blood pressure. I'll clamp down on you, right? And then what happens is you start to get all those hormonal changes, and we talk about beta blockers, they reduce remodeling of the heart, ACE inhibitors reduce remodeling of the heart. That's what we're actually doing, is trying to stop that increase in SVR that's actually ultimately bad for the heart. And so what's interesting, if you think about it, is you have your heart trying to beat out, and then you have your vasculature that's all clamped down. So now you've got this poor, sad left ventricle that's trying to push into your arteries, and they're all clamped down. That doesn't seem very nice, right? So if you give the patient something that dilates them, reduces their SVR, you can actually increase how much the heart is able to get out, which is very interesting. So when you give an ACE inhibitor or hydralazine or isosorbide to a heart failure patient, it may or may not actually decrease their blood pressure, which is really interesting. It may actually improve their hemodynamics because it allows their heart to beat more. It's not that it didn't reduce their SVR in this equation, it just maybe also increased their cardiac output, which is very interesting to see. But again, I didn't put it as something that we were going to do today. I think that's a lot of changes to make very quickly. Okay, so again, I kind of want to point this out. I love this moment too, that this was in here. This is exactly as it was in the chart. It says heart failure reduced ejection fraction appears to be at baseline, not acutely decompensated, and it says plan hold all hypertension and HF meds given cardiogenic shock concerns. This is like a classic note. What they do is they just copy and paste things from day to day and then update little bits and pieces. They don't actually read it. And so the notes tend to be less and less helpful over time. And that's why you have to actually look at what the MAR says, look at what the patient's actually doing. And that's why I'm saying please think through it. Because if you're just looking at the note, you're not going to have any idea what to do. And again, this is like exactly real life. I should also put a caveat that hopefully this is getting you ready for APPE in real life and getting ready for the exam. But we're not going to be this knee deep on the exam, okay? Okay.
Dr. Newsom?
Yeah.
Instead of adding hydralazine, why wouldn't you just discontinue the enalapril and initiate Entresto? Because the ACC and AHA heart failure guidelines recommend that in place of an ACE inhibitor. And it reduces CV death and hospitalization by 20%.
I totally agree with you. Entresto is a great medication. If you, let's say I can think of one reason I don't want to do it today. Can you give me one reason why you don't want to today? I agree. I can't wait a week from now. You would be right.
Well, we want the AKI to resolve first, but upon discharge, wouldn't that be sufficient to do since he hasn't had the enalapril in over 36 hours?
Yeah, so I agree with you. I think that you can, like this, that would be ultimately a very good choice, that once you feel that his AKI has resolved, to start Entresto. The reason that I said hydralazine isosorbide there is that sometimes what happens in the inpatient setting is we're just trying to get that SVR reduction to improve their cardiac output. And then when we see that improvement in cardiac output, it improves their renal function, because remember they're perfusing now. And then when they look all pretty on discharge, we'll get rid of the hydralazine and start Entresto, which is kind of wild, I know. So I agree with you. Again, that's when I kind of joke, but I'm serious also about the checky box. If you told me that on rotation, I would say, please remind me every day, and we will look at it every day, and one of the days we're going to do it. I just don't know if it would be today. But that is an excellent point.
Thank you.
Yes, thank you. It's a great point. All right, what's the next biggest thing that had you guys all worked up? I forget what group we're on. 16 sound good? Or 17?
He just had stents put in.
Huh?
He just had stents put in not too long ago.
Yes. So I'm getting here, he just had stents put in. Yes, fresh stents. Stents a week ago, that's a big deal. That should always be pretty high on your list differential. The reason why this is such a big deal is that fresh stents are a very high thrombogenic risk, okay? So for you to take off a medication that's reducing thrombogenic risk, you are definitely in a window where that would be a problem. So we actually, I was finishing up a review paper with some people that I did residency with, and the whole point of this review paper is what do you do with a patient that had an MI with fresh stents that now needs a surgery? How do you do that? And so do you bridge them with a 2B3A inhibitor? Do you give them Cangrelor? What is the perfect amount of time for them to be off of it? Because it's such a high risk for them to be off of that medication, but obviously it causes bleeding and the whole 9 yards. So what is the risk benefit? So hopefully, this to me shows up as a big medical problem. So given that, what do you think the biggest medication-related problem is as a result of this?
The triple thrombotic.
Yeah, triple therapy. This to me now, you really have to make a decision as to how do you feel about this. Okay, so let's talk about this. So again, you're looking at your STEMI, PCI, evidence-based medicine. You've got aspirin as a class 1. Beta blockers are class 1, statins are class 1, ACE inhibitors are class 1, and then clopidogrel is class 1. So the good news is he's on all of these. I didn't put ACE inhibitor, he's not on ACE inhibitor yet, and we have the beta blocker that we just started today. So we're moving in the right direction for him. As we discussed, he ought to be on Entresto or an ACE inhibitor by the end of the hospitalization. So we can feel okay with that. Again, stent thrombosis is a really big deal. The highest risk is the first 30 days after. A week ago, it's pretty fresh, all right? So in general clinical practice, early stent thrombosis is about 1%, and then it goes down significantly after that. Even though it's only 1%, you have a mortality rate of close to 50% in some of these patients if that actually happens, with an MI rate of closer to 70%. Because again, you have this area that was just freshly atherosclerosed, and you just kind of propped it open, right? So this is definitely something that's a pretty high concern for us. Then we go through his CHAS-VAT. So I heard what did you guys decide, 5, 4, something along those lines? So I screenshotted this. This is actually me doing this in MedCalc, going through his age, gender, heart failure, getting to a score of about 4 points here is what I have, and that has blood score of 2. And so this is something that we do a lot in inpatient. And so we say, okay, he has a score of 4, which confers a 4.8% risk of him having stroke, TIA, that kind of thing from his AFib. But then, because of all these other risk factors, he's also got a 4% chance of bleeding, according to this. So kind of a wash a little bit, right, as to what we want to do. If you really want to get into the weeds of something like this, you might want to ask me, what type of bleeding is it that has a 4.1%? So in this case, is it an intracranial hemorrhage, which is a much bigger deal than maybe having some bruising versus GI bleed, that kind of thing. But he does have, as high as his risk is for a stroke, he does have fairly high bleed risk. So what are we going to do? So, did anyone find this white paper on triple therapy? This is like hot off the press. Came out August of this year. All right, I highly recommend taking a look-see at this, but we'll go through it. All right. So this has been an ongoing debate over the past few years. Actually, when I was taking care of this patient, this paper was not out yet. So we spent a long time talking about this, and what we ultimately decided at the time for this patient was that we would continue triple therapy for at least 6 months because of his recent MI and things like that, and we would continue a PPI. Fortunately, this has come out, which has been really, really helpful, and it was a white paper by American Heart Association. And so what it says is it gives you this lovely little chart that tells you exactly what they think you should do. So basically where we are with him is that he can probably be on what they're saying is double therapy. So he can be on a P2Y12 and Eliquis or Pixaban. And then it goes into kind of all the reasons why we would do, like, gives you the rationale. It's a very nice paper. I highly recommend saving it to your nerd files. You will definitely reference it next year at some point or another. So what it talks about is your default strategy here versus patients at a high ischemic thrombotic risk versus a lower risk. The question becomes, how do you define high versus low? I think the default strategy probably works for him. But if you wanted to make an argument with me about why you put him at high or low, I would listen to you very openly, I suppose. So given this, I would discontinue the aspirin. That to me would be his next biggest problem. So I got rid of the Noronome, and now I'm going to get rid of this aspirin, and I'm going to continue a P2Y12 plus a Pixaban. Going with double therapy means we can also address, does he need a PPI if he has no history of GERD or a GI bleed? If you guys tell me he has GERD, so I guess we're stuck with it for another day. Okay, what's the next biggest problem you guys have? What are we at? 19?
Dr. Newsom,
Yes.
can you explain why you DC'd the aspirin and not one of the other two?
Yeah, so what was really interesting is there's a couple of different trials that have come out. There was, WOST and several others. Now I gotta go to my nerd files about it. So triple therapy. Yeah. This is this little editorial that I really love. I highly recommend reading this too if you're actually interested in this, because it's a nice little read. So basically there are a couple different trials. I was forgetting their names. So there's WOST, Pioneer AF, and then REDUAL. And the way that these trials were set up, they were done shockingly by the drug companies with the drugs that were aspirin. And so what they found is that they were able to, when they took off aspirin, dual therapy was better. So you can see this lovely little chart here kind of showing that dual therapy was better. So the reason why I recommended taking off aspirin is just because I'm going with how the evidence was, what the evidence says, I guess, and how the trial was designed that showed that you weren't seeing any increase in major cardiovascular risks, but you were seeing reduction in bleeding. That's an excellent question, though. The first time someone told me to get rid of the aspirin, I also felt sad about that because I think aspirin's a great drug. Alrighty, so I just gave you guys the answer here. So the next biggest problem. So we've already kind of talked about this. We kind of identified shock liver, right? So we saw elevated LFTs. Was their INR up or down? What did you see for their INR? Up. Can someone explain to me, what do you think is a true test of liver function? AST, ALT, or INR?
INR.
Yeah, Yes, INR, absolutely. So I think this is one of the biggest misnomers in all of medicine, is that truly the test of liver function is INR and albumin, because you're making proteins, right? So INR goes up because you're not making all of your clotting factors. Similarly, albumin will be down. Whereas I think a test of liver injury is going to be AST, ALT, all right? So for him, he's showing signs of both, actually. So for, let's say, I don't know, I'm relatively young and healthy, but I have a bad night and I don't know, get in a car accident, lose a bunch of blood, and I go in and they see, oh, her LFTs are a little bit elevated, her AST and ALT are up a little bit. That's probably because I have lost a bunch of blood, they need to give me volume, and as soon as I get volume and blood products, my AST, ALT are going to go right back down. Because I'm young, I'm healthy, I don't have any liver problems, it's going to be fine. Whereas a patient that's a chronic cirrhotic, maybe an alcoholic, you're going to see that they actually, ironically, might have normal LFTs because all of their cells are basically dead, they have nothing left to injure, but their INR will be elevated and their albumin will be low. So what do you think we should look at given their shot liver? What speaks to you as an issue? We already talked about the apixaban, which is a great one. I'm going to add that next year.
The statin.
Yeah, I think looking at the statin. So what do you think we should do? What are your guys' thoughts on this? Get rid of their statin, just watch it, hope for the best.
They seem to be getting better, so I think it'll be okay. And the risks, or the benefits, most likely outweigh the risks.
Yeah,
I would keep it.
I'm kind of hearing over here, they seem to be getting better, with kind of a little question mark at the end. What was
They
it?
just had an MI, so I would keep the statin.
Yes, I just heard, they just had an MI, yes. So I agree. What I'm trying to show you guys here is this is again, what makes clinical pharmacy so fun, makes working in the ICU so fun. I agree, he definitely had shock liver. I definitely don't think he's all the way normal yet. But I do think it's getting better. I do think we're fixing him. We're doing all the right things that way. And you're right, he's had an MI recently. And so to me, a statin is an excellent thing to keep going if at all possible. So I am a huge believer in statins. Like that is definitely, there are very few situations where I want to get rid of your statin. I have a painting of the forest plot of the heart protection study, which is like the original statin study in my office. That's how strongly I feel about statins. And so there's actually some interesting data on statins. They call it abrupt withdrawal. And they actually have found that when you abruptly stop the statin in-house, the patients have worse outcomes for all sorts of reasons. So you bring them in for any reason, and you're like, oh, you stop their statin for a little bit, they actually do worse. And that can be regardless of their recent MI. And that's because the beauty of statins is not really to do entirely with lipid lowering, it has to do with all those lovely pleiotropic effects, right? So basically you have a patient that just had all these anti-inflammatory things going on from the recent ischemia, and this has all these lovely anti-inflammatory properties. So I agree with you. So recent MI makes the patient pretty high risk. Ideally, we would continue the atorvastatin. I do think it is reasonable to say that you would monitor the LFTs. Okay, this is definitely to me a medication-related problem in that you do need to continue. You're leaning to one side, which is to continue it. But I think we're all hedging a little bit. We all know there could be a possibility of something else happening. We're not going to like, all right, they're fine. We're gonna keep monitoring, right? So, yes. All right. Oh, this is a little diabetes thing. So you guys tell me you found some history of diabetes. So let's work through this. Tell me what blood sugar ranges you guys found in the chart for this patient with their potential history of diabetes.
He gets immunoinsulin 3 times over the last 2 days for a blood glucose over 180, and there's just a diagnosis of type 2 diabetes in some of the notes.
Perfect. So when you guys think about, he's had over the course of the last 3 days a blood sugar that was mildly over 180 at 3 points. Do you guys think you ever had a blood sugar over 180 in the last few days? Yeah, like I know I did, right? I had some chocolate before I came in, right? It was great. I don't have diabetes. So the question is, if you take a random blood sugar reading at some point in the day, you can potentially make a patient look like they have diabetes, right? Even if they do or not. So this to me is a classic one where I also like to talk about like my father-in-law. He was a little bit heavy. He liked real Coke, those kinds of things. He's a Southern man, likes fried chicken, all that kind of good stuff. and gets a diagnosis of diabetes. They put him on metformin. He loses like 120 pounds. Now he doesn't really have diabetes anymore. It's in his chart, but if you look at his A1C, you look at his blood sugars, I'm not really sure he needs insulin at this point in-house. So someone mentioned to me that they didn't have an A1C. I'd be thrilled for you to get an A1C because then we could know where he's at. And maybe this is something that is a remnant from years ago when he was drinking real Coke and now he doesn't. Maybe his A1C is 10 and this really is a problem. I would be down for that. But I do think that just because you see type 2 diabetes in the chart doesn't necessarily mean you need to stick this guy 5 times a day, nor do I really think that 3 units of insulin over the last 48 hours is like making or breaking this patient, right? Okay. Awesome. Thoughts or questions on those problems? I know this is a lot of information, but do those problems at least now make sense to you?
For the liver injury, would you not want to monitor INR too, because that was increasing even though the ALT and the AST have been decreasing?
Yes, please monitor that. I will update that as well. Tell me why the INR might be up that does not have to do with his LFTs.
Eloquist is too high because of his kidney function.
I heard maybe some Eliquis. Yeah, there's it. It could be. I asked it not really having an answer. I was just curious if you guys could come up with something. I agree. I think that we should continue looking at the INR, and I think that would be an excellent reason to continue monitoring. But again, I think unless I saw unless he started complaining of muscle pains or we're seeing CK elevation, something like that, I'm going to try to ride the statin out as long as I can. But I definitely agree, if you want to take an extra look at some coag tests, I would definitely give you a thumbs up for that.
Dr. Newsom?
Yes.
Okay, so the primary problem was the cardiogenic shock secondary to the heart failure. So if there was a lot of problems with his heart failure meds as well, would we just throw all of that in one category, or because it's secondary to it, or would we just do cardiogenic shock and then do heart failure separately?
So this to me is a little bit where we're going to go in the next few slides. So you're probably saying, I want to add Entresto, or I don't like that he's not on hydralazine, or whatever medication that speaks to you that you would like to start. The question is, do you think you should start it today? And the point is, with a heart failure patient, it would be nice, we're all kind of type A in pharmacy school, we want to check it off the list and keep moving. In real life, these are patients that are here with us for a week or more even, because we're making small changes every day and seeing what's happening. So we will definitely go over those, but I would say, the fact that the patient is not on an ACE inhibitor, it is a medication-related problem at some point, but today I don't think it is. I think it's more of a box that I'll make a problem later on. Does that kind of make sense? Like, I actually think it would be bad to start him on an ACE inhibitor today, or Entresto, whatever.
I get it, thanks.
It's a great question. And again, if you were on rotation with me, what I would say is keep that on your list for tomorrow. Okay?
I have another question for you, about the abdominal pain. The notes when he was admitted said that he was throwing up some blood and it subsided. Do you have any thoughts or anything on that?
Yeah. It sounds really dramatic, doesn't it? He's throwing up blood. What was his H&H? Did it look like he was acutely bleeding? Where was he? What was his trend?
I think all that was like when he was still at home, and then when he came in, it was not happening anymore.
Right.
The hematocrit and hemoglobin were actually low, and his prothrombin time was also elevated as well as the INR. So, and a urinalysis from the day before said there was blood in the urine, so we saw some signs of bleeding.
Correct. So there's a lot of things happening that can point you to it, and I know I sound very cavalier and disinterested, so let me kind of explain why. So, one of the things that immediately happens to any decompensated heart failure patient that is a male is we're going to put in a catheter. I don't know if you've ever seen the size of a catheter that they put in a male. It is shockingly large. Like it made me blink the first time that I saw how big it was. So frequently you can see what they call a traumatic cath because they literally, you are damaging the urethra as you're putting it in, so you can see blood in a UA, and that can be an issue. I agree, throwing up blood at home, that definitely was one of the things that kind of led me to, I don't love this triple therapy thing that's going on. I think it's a great reason to keep a PPI on board, so I think we kind of made some moves there, which is that we got rid of the aspirin, we're going to keep the PPI. The other problem that's hard with this is patients will say this, and then kind of on further review, you found out that they like drank some red Gatorade or something, and so it's like, was it actually that or not? And then you have to look at what his H&H are. And his H&H are low, I do remember that, but at the same time, are they trending down? Or are they staying stable? Is he just
trending down from the lab on 113?
So what was the difference? So we're at 12 here, 12 and 38, and 13, 41. So this is kind of in that one gram hemoglobin drop, and I do think that that is something that is worthy of note. I think this is potentially within, to me, an error range of the lab, and you would want to have an overall picture. The other thing you have to remember is that we also we joke that we're kind of like vampires in the unit, and so we're like always taking blood. And so if you watch a patient in the unit, they all drop at some point. So then the question becomes, okay, I'm still not giving you a good answer, and you're like, it seems like he's bleeding. What is the biggest problem with bleeding that you'd be concerned about? Why is bleeding bad? Why is a lot of bleeding bad? What could that cause?
Shock.
Shock. Do you guys think he has shock anymore? I'm seeing some head shakes, right? We're kind of all feeling good about his shock, actually. So to me, I think this is like something that is worthy of note, worthy of paying attention to. I feel good about taking off the aspirin. I feel good about keeping the PPI. But I think I need him to pronounce himself a little bit more, declare himself a little bit more that he actively is bleeding, given that I think I can kind of explain away a lot of the other things. All right. So one of the other kind of gut check things that I like to do is I like to go through and kind of try to assign medications within the systems and make sure that I've touched on every system. So within neuro, he's got this Zoloft. We kind of decided that he maybe has depression, but maybe not, and we're not really sure. This is something where if you can't find it in the chart, we need to go talk to the patient and see who's on it. He was on it at home, correct? It was a home medication for him. This is not the best thing. Arpita, who was one of my favorite pharmacists at AU, used to say home medications are not an indication, and I would agree with that. But I do think that it's likely that he has it. We just need to go find it in the chart. To me, his biggest neuro issue would be, I would consider the pain, which is the resolved abdominal pain. So the fact that we probably would continue evaluating to see if that's resolved, staying resolved, would be important. So if he came to you and said, my stomach's starting to hurt, now you have an argument for me about maybe he is bleeding. All right. So now he's got like 85 other heart issues, right? So this is truly what a heart patient looks like, or a cardiac patient looks like in a hospital. They usually have multiple things. It usually is overlapping, and you're having to decide what is the medication for, and what are we keeping or not keeping based on that. So these are all of the things that I can think of that he's got. So again, in terms of his CV, he's got metope, spironolactone, atorvastatin, Lasix, aspirin, Plavix. So these are the things in the CV. Do we feel good about those? Oh, and the Milrinone, of course. We're getting rid of those. So one of the things that I think is helpful is to differentiate between acute and chronic. So I'm going to click through this. So to me, the acute issues is the shock that we've been talking about, and we feel really good about this now, beating that into the ground. Then we start looking at the chronic stuff. So, okay, we're going to talk about the fact he has AFib. We've got him on metoprolol. His heart rate is hopefully reasonable. We're going to get it reasonable. Again, we can't necessarily fix his heart rate today, even if it wasn't, because we're not just going to slam him with a beta blocker when he was in shock 48 hours ago, right? So it's maybe a problem we're going to continue to think through. There we have him on Eliquis, which we feel good about. Then we have to think about what is the goal-directed therapy for his heart failure. So what are the medications you can think of? So we have him on metope, we have him on spironolactone, we have him on Lasix. I've heard Entresto. What else, you guys, would you want to add potentially?
Are you asking acute or chronic?
Chronic. Let's say we continue the pain and you're having to take care of this patient 3 days from now. What else would you want to add? Potentially, anyway. So I kind of create a list in my head of the things that he could be on, and I just kind of keep this and I kind of start going through. So spironolactone, we have him on that. Beta blocker, we've got him on that starting today. He's not on hydralazine isosorbide. That could be an option for him eventually. He's not on an ACE inhibitor, but we're saying that maybe we're okay with that because we're going to go to Entresto and feel good about that. He's on some Lasix, of course, figuring out what is the euvolemic dose for him, but we seem to be okay there. And then ivermectin, but I don't think he's a candidate for that, so we feel okay. So to me, I think the hydralazine isosorbide, ACE inhibitor, and Entresto, one of those would be the direction we want to go. All right. From a pulmonary perspective, ironically, I would put Lasix within the pulmonary category, even though it affects kidneys, and that is because, of course, if you have water in the lungs, they're going to start complaining of shortness of breath, correct? So we look at things like the subjective stuff, what is his volume status, and then objective things like his blood gas, his respiratory rate. So I'm going through this because I kind of want to make sure you guys see the things that you were looking at, but again, hopefully you guys didn't come up with too much in the pulmonary section, because his blood gas was normal, his respiratory rate was normal, that kind of stuff. He's got chronic lymphoid orthopnea. Do we need any further values? Do you guys want any more EEGs? Kind of getting like, why are you asking me that on Augusta campus? I agree, I don't want an ABG either. This is a very classic question that happens where all of a sudden we look at it and we've got an ABG every day for a week, and now we're complaining about the fact that his hemoglobin's low, and maybe this is one of the things we could stop vampiring him about, right? What other systems would you think for a patient like this play into their lungs, their pulmonary status? I can think of 2 other systems that I kind of want to interconnect in my head.
Kidneys?
Absolutely. Kidneys, and then, of course, his heart. Those would be the 2 that I'm kind of thinking about all at once, and they're all kind of interrelated. Awesome. All right. Tell me about his kidneys. Do you think he's getting better? He's getting worse? And how are you making that decision? I forget what group we're on. Are we on 20 yet?
His serum creatinine is going down from when he got admitted.
Yes, serum creatinine's going down. What other things could you use if you had them, or what else can you look at?
Oh, the urine input and output?
Yes, I's and O's, all that kind of stuff. So sometimes I joke that I feel like I make a lot of my big time decisions based on my assessment of their kidney function. I know I had a couple of students that make fun of me where I go, oh, it looks like they can handle 2Q12-17. And they're like, they look like it? I thought we were going to use the creatinine clearance. But it's because I'm using a lot of other things. So let's talk about a few of those. So other things that I would use besides serum creatinine would be I's and O's. If you have ins and outs for that patient, you have a urine output, you have an overall balance, you have electrolytes, those things can all play into what's going on with the patient. So what's interesting with a patient like this that has acute kidney injury, they can have what's called high output acute kidney injury, which is where they actually still have a fair amount of urine output, high output, but they don't filter very well. So their K is like 6. Or you can have a patient who has low output AKI, where their K is 6, and they're also not urinating very much. So the question is, when you guys looked at his electrolytes, were there any electrolytes that were like really out of whack? Specifically potassium, phosphorus?
When I looked in the chart, I couldn't find electrolytes.
No, don't tell me that. Okay, here, I got one at least. We got a potassium of 4. How do you guys feel about potassium of 4? Does that speak to you of an inability to filter?
No.
Okay, good. I agree. It's a great potassium. And I don't see a phosphorus here. Well, if we had a phosphorus, we can look at that one too. I had one of my preceptors who used to say, oh, you can always look at the phos to know about their AKI. And I was like, Ed, can't we just use the serum creatinine? But it is true, if you see a acute bump in phos, it often has something to do with filtering. This is a question I always like to ask. If I tell you that the patient is 60 years old and they weigh 70 kilos and they've got a creatinine of 1.5, and they're a boy, and their urine output is 0, what is their GFR? For all intents and purposes.
0?
Yes, 0. Okay? So the joke I like to make is that if you have a pulse, you can have a creatinine clearance. Because everyone has a gender, everyone has a serum creatinine, everyone has an age, and everyone has a weight. And that's great. You can calculate that on anybody. But it has not necessarily has much to do with actually what's going on with their function. It might lag behind. And that is why looking at overall urine output can be very helpful. So within all of these things, to me, this patient, as we're saying, he's filtering well. We don't see any signs of gross fluid overload, and his creatinine is trending back down. I feel pretty good about his kidneys. Is that a reasonable assessment? So I don't see that we're going to have too many problems there. We don't need to start phos low. We don't need to do anything like that. I think we can just kind of hang steady here. All right. Endocrine, we've already kind of talked about his diabetes and his synthroid. A question for you guys. I do not want to get thyroid levels on this patient to monitor his levothyroxine. Do you guys have any idea why I don't want to do that? Just because I want to go to lunch early? I'm hearing stress. So yes, stress. And what might stress do to your thyroid levels? It's a classic residency trick. You don't know if it's up or down. You can just say change, right? So you just say it alters them, right? Yes. So yes. So this is a key thing. So critical illness shock can alter pretty much all protein levels, but it can specifically alter thyroid levels. And so the values that we get can be completely crazy, and they're also completely meaningless. So I cannot even tell you the last time that I looked at a T3 or T4 level in-house. I have to look up the values at this point to make sure that they're normal. I just continue them on their home dose, and if we think that they're having an active thyroid issue, we'll bring an endocrine, we'll do some more workup, and we'll try to do something in the acute phase. But really, we're not going to make any changes to this patient because of the acute phase of their illness. One of the great things about critical care, some of the chronic management stuff we don't have to worry about too much. All right. So we've kind of beat heme to death. I do think that you guys made a great point about looking at bleeding. And this is, again, one of the things that I hopefully you'll realize won't be this mean to you on an actual exam, but also rotations will be this mean to you, where everyone's going to have trending down H&H, and you're going to have to figure out what the workup is for this and what do you want to do with it. In this situation, I totally think that there are things that we can do to reduce his risk of bleeding, aka get rid of triple therapy. But other than that, I think we're moving in the right direction. In terms of monitoring, again, I'm always going to put H&H and platelets on there, INR, AETT, and we'll continue following from there. ID. What do you guys look at for ID to decide this guy? Why have we talked about sepsis? What was that? Sorry.
Like the shock will decrease the immune system. They could have a decreased immune system.
They could, potentially. Critical illness can definitely make you be immunocompromised. What are the things you think about when you think of signs and symptoms of infection? Does he have any of them besides potentially hypotension originally? What about his white cells? Low. Okay, so So low to normal potentially. And does he have a fever?
No.
No. Does he have any purulent anything? Complaining of cough? Yeah. I don't see a huge reason to have any concerns for an infectious etiology to this. But again, something to always look at, right? So I would say a normal-ish white count, no fever, no other signs and symptoms of infection. We feel good, but we're going to continue to monitor, right? In real life, this is a patient where you come in and they look exactly like they do, and the patient's on vancomycin as well, and you're like, why are we on vancomycin? And they're like, oh, well, they were in shock. And we're like, are you sure it's not just their heart? You know? And so then that's a classic conversation. So that could be a way that I could up the ante for you next time is put vancomycin on there, and you guys have to convince me that we need to get rid of that. It would not be hard to convince me that we do not need those. All right, hepatology we've kind of discussed. Again,
Dr. Newsom?
Yeah.
Under one of the labs, I think it was maybe a urine test, it says +1 for bacteria, and the reference range says none.
Yes.
What does that mean then?
Oh, that is a toughie. So, to your point, there should be, urine should be sterile. That should be sterile for boys and girls. For girls, you will often see +1, not often, but you will see a +1. And the first question you have to ask is, was it a clean catch or not? So if it passes through and it's not a clean catch, it may or may not be sterile at that point because it's collected something from the outside world, so to speak. Again, for a catheter, catheters are definitely exposed somewhat to the outside world, so you can see some contamination. So one of the classic things that has to happen when you have a UA is that you need to have, they'll often say, can we just change out the Foley and try again? And you'll find that then it is clean. And so if you look at the diagnostics of a UTI, you don't necessarily want to look at just culture because you can grow all sorts of goodies and if the patient doesn't have any signs and symptoms, it's not super meaningful. So to me, when I see a +1 like that in an ICU setting and the patient has no signs and symptoms, they have no fever, they have no white count, they're not hypertensive, well, not hypertensive anymore anyway, I would just kind of shrug that off as contaminant. But again, I think it's good for you to keep in mind because if the next day the patient complains about burning or flank pain, then you say, hey, maybe that was real after all. Many things are your best guess, and the next day you have to say that guess was not the best after all. But that's a great eye for detail.
Dr. Newsom, I noticed a couple of things in the radiology notes that weren't mentioned. I was wondering if either of these things were significant. Said bilateral hip osteoarthritis, and then that was, I think, the CT scan, and then in the transthoracic echocardiogram, it said possible thrombus in the right atrium.
The possible thrombus in the right atrium, my goodness. This is a funny one that we'll talk about. So, I did residency. I spent more than half of my 2 years in a cardiac unit, and I never saw anything to do with thrombus in the right atrium. If you would ask me if that disease state existed, I would have said no. I had never seen it before in my life. And I came to AU, and we have a slightly different imaging system, and they put that on like every note. And they'll say, oh, there's a thrombus in the right atrium, and then we anticoagulate because of it. And that totally blew my mind. And so I remember talking to one of the other cardiology pharmacists, and I was like, did I just like miss this in residency? Like, what is going on? And she's like, Andrea, this is one of those things. She goes, year 1 for me, it was all over the place because of the imaging. Year 2, it was not. And the data on that is like very, not contradictory, conflicting, I would say. But let's say he does have a possible thrombus in the RA. What are you going to treat him with?
Would it be what he's already taking for the triple therapy?
You got it. So he's on an anticoagulant. So we're just going to continue that therapy. But again, what I'll tell you in real life is like when it'll be there on one read and it won't be there on the next read because it's like a shadow. And they'll be like, that's why they say possible, because it kind of like comes and goes. But regardless, he's got AFib, so we're going to keep him anticoagulated. But again, that's a great eye for detail, and I like that very much. In terms of his osteoarthritis, I did not do anything with this from a clinical perspective because I was very much in an ICU mindset of like trying to get him out of the unit, optimize on his heart failure meds. But if you want to put that as a box, I certainly am not going to stop you. And then we're going to need to do a T-score, a Z-score, and all, you know, all that kind of good stuff. But I am going to defer that to the outpatient setting if that's okay. Awesome. What are your guys' thoughts? Do we need a lipid panel?
No, because we're going to keep him on a high intensity statin.
Yes, I feel very, I do not necessarily feel the need to get a lipid panel in this setting because I think that we have a very, very compelling indication for high intensity statins, pretty much a level 1. I guess the argument on the other side could be, what if he has an LDL of 20? Would you continue it anyway? This can be a very interesting clinical debate that is going to be beyond the course of this class. But I do just want to point out again that I think that to me the primary things that we're monitoring with the statin are the fact that he's got a primary indication, making sure he doesn't have, that we're monitoring his LFTs, making sure his function is improving, and we're going to try to ride that out as best as we can. If you want to say a year from now you go with the panel, follow those guidelines, I'm fine with that. But right now, I feel okay. FENGI, he is on Protonics. I don't see anything else from this perspective, but things I think about are they on any fluids? Do they need to be on fluids? Do they need any type of nutritional aspects? He's on a cardiac diet. I've actually become much more attuned to a patient's diet orders, clinically speaking, because the patients complain about it. And so they'll come in and you're like, how are you, Mr. Smith? And they're like, why haven't I eaten breakfast? So at this point, it's like kind of in the order next to the medication, so I usually just glance at it, and then I'll ask the team, like, hey, do you know that they don't have a diet? Because they're definitely going to ask about where breakfast is. But I didn't have anything from this perspective. Did you guys have anything that you wanted to add to this section? Awesome. From a prophylaxis setting, why is he not on sub-Q heparin?
He's on full dose anticoagulation.
Yeah, he's on full dose anticoagulation, which is great, so we should not add that. This is also a classic thing that you will see where everyone's like, oh, they gotta be on sub-Q heparin, so you'll see that they're on full dose anticoagulation and sub-Q heparin. So we actually have an alert in our system in Theradoc where it tells me this because it happens all the time. Other things to think about, so we have him on a PPI because he had it at home. We're saying he has GERD. He's basically DVT prophylaxis, Eliquis. He's not mechanically ventilated, so we don't need chlorhexidine. He doesn't need any high lubricant. A bowel regimen is something interesting to consider. You know, I don't know if you guys travel or you get out of your normal routine, you notice you get a little constipated. I think that's probably a pretty typical experience. I would say that being hospitalized for cardiogenic shock is probably the epitome of traveling and being out of your day-to-day routine. Constipation is a pretty normal thing to see in the unit, up to like 80% of patients. So it's something to at least consider and keep an eye on. A lot of patients will be very happy with you that you put them on a little bit of DocuSafe, kind of keep things moving along. All right. So again, if you want to organize what we talked about today in terms of the medication-related problems, I don't have Entresto on here, but I'll add it for needs additional therapy, because I think that's a very good point. So potentially we can get rid of the sliding scale if we don't feel compelled about it. We can discuss the beta blocker versus the inotrope, which one we're going to get rid of. We're going to get rid of the aspirin. We're always going to be looking to titrate heart failure meds. Again, you definitely want to get to your max dose of beta blocker. The question is, are we doing it today? All right. So for the exam, we're not going to be able to do this for you. So please don't worry about it from that perspective. But I want you to see how this actually works in real life, which is that today we can feel really good that they're on metoprolol tartrate because we're just happy that they're on some beta blocker. But the fact that one of you said that succinate is what's actually been shown in heart failure to improve mortality, you know, A+ for that. I hope that when he gets discharged, we have him on succinate. So that's going to be something prolonged that you're always thinking about. We're going to continue monitoring LFTs. We're going to think about adding some other therapy as time goes on. Feel good about that. You guys have been an amazing class and audience today. What other questions can I ask or can I answer for you? What other things would you like to see? Any other thoughts or concerns?
I
Yes.
saw like an elevated lactate. Is that just secondary to the shock? Or
Ooh,
is that
yes.
like an issue?
Great question here. It was, I saw an elevated lactate. Where did that come from? So yes, elevated lactate is an excellent indicator of shock. I think he only had one level though, right? So this is a very classic thing that we do, which is where we get a level and like, oh, it's high because they're in shock, and then they kind of start to get better, and we never actually follow up with another lactate. Ideally, we would get a lactate to make sure it's normal. So not to say medication-related problem, but how about like a patient-related problem? I probably, would have asked to say like, hey, can we just like confirm that we're in a good spot? But yeah, it just it shows lack of perfusion, anaerobic metabolism, if you will. It's a great point. What else do you guys find?
I have a question more so about the quizzes for this class. Are we going to have access to the internet so we can look at primary literature and guidelines and stuff like that?
With regards to these, like the quizzes, I think are on lockdown. Yes. Okay. Yeah, you'll be able to have all that. There's no way you can have all this memorized. I don't know. I mean, you saw me looking at stuff in class today. There's no way you can have all that. And to me, pharmacy school in many ways is learning and residency, learning all the things you don't know and then learning where to find them. It's two different types of knowledge, but yes, you'll definitely have access to that. Someone told me a trick of the trade that they did last year was that they pulled up their, like, what they thought were the 20 most common guidelines, and they put them in a Dropbox, or they put a link to them so they could just click on them quickly. I don't see any reason why not to do that. You know, there's bets are good that you might see hypertension, diabetes, basic ID on the exam, you know. There will not be this white paper on there, but you can put it on there just for good measure.
Are we typically gonna have to turn these in? Because it's easier to write it out than
The question over here was, do I have to turn these in? I was not planning on taking them from you. Dr. Phillips, if you're here, you can correct me on it. You don't have to, if you'd like to write it out, that's each his own, in my opinion. I don't like typing things out either because it autocorrects and the numbers get weird and stuff like that. You know, my other point for you guys when you're using the sheet, don't write down things that are normal. Sodium is 136 and you feel good about it, don't write that down. It's a waste of time and clutters things up.
Hello, Dr. Newsom.
Yes.
Just a quick question. So did we did discontinue the proton pump inhibitor, or we kept it?
We decided that he had GERD that we found in the note, and so we kept it for now. I keep hedging about it because I'm always annoyed by proton pump inhibitors for GERD, more so my own work. But you can definitely keep it, and you can make a good argument for that.
Okay, thank you.
Yep, you're very welcome. Dr. Bland was telling me that he was answering questions about this case, and he goes, I knew by the level of stress that it had to have been your case, Andrea, and I was laughing. I do want you to realize a couple of things about this case. This probably is one of the most difficult cases that you'll have over the course of this semester. It's a difficult patient in real life to take care of, but I also find that the toughest patients are the best teachers, so that you can think about all the different thought processes. So hopefully, although maybe it's a little bit traumatizing for round one, hopefully someday you can realize that it's actually quite fun to take care of a complicated patient like this, and that it is your opinion. So a lot of times I'm saying I would keep atorvastatin, and this is the reasons why, but someone else, you could totally argue with me that we should get rid of it, and that would be a reasonable course of action as well, potentially, okay, with the right set of actions. So I just want you to know this is what makes clinical practice so much fun, what makes working in the ICU so much fun. So again, what I want you to take from this are the principles of how we got to the answers, more so than saying, you know, like you're like, I don't know if I would do that again or not. Again, the exam is going to be much more clear cut, but this is much closer to real life, and I think that real life patients are for sure our best teachers. And when you read those notes and they seem mildly nonsensical, again, that is real life, and that to me is the whole purpose of this class. So hopefully, I think you guys did an amazing job with the discussion today. I think the level of questions shows all the right things and all the right thought processes. So I hope you guys feel really good about yourselves today. the level of conversation and discussion today makes me feel very good about where you guys are going to be by the end of the year, okay? If you have any thoughts or questions, you have any more concerns, always shoot me an email. Thank you all.
Thank you, Mason.
Yes?
I think you said bye.
Oh, all right, bye guys.
Dr. Newsom, are you there?
Yes, I'm here. What's up? What's up? I'm here.
Oh, thank you. I just had a quick question. Would you change the PPI to H2RA or, since it is, I guess, cardiac and heart code, I know that they said to switch it or something like that?
Yes, I would, but I cannot necessarily back that up with like a guideline, so I didn't put it in here because I thought that would kind of stress you out. I would probably use an H2RA in this situation for sure, unless you could really convince me that he had a strong history of a GI bleed or something along those lines. But that is very much I would say, a quirk of my practice, and we could have an hour-long discussion on the pros and cons of that. But it's a great question.
Okay, thank you.